Good afternoon, everybody. Today our group would like to do a presentation for ARDS, also known as acute respiratory distress syndrome. This presentation will be presented by myself, Michael Stevens, Sherman Steverson, and Tawanza McClendon. We are a group of students at the Mississippi University for Women completing this presentation for professional perspectives and complex health alterations to health. We're under the direction of Michael Calvary. Some of the objectives we'll be covering today, we're going to be looking at the definition and description of ARDS, the history, key facts, incidents, risk factors, the pathophysiology, some causes, and common signs and symptoms of ARDS. We're also going to be looking at the diagnosis and prognosis of ARDS, how is ARDS actually diagnosed, some severity ratings, any possible treatments for ARDS. We're going to look at any ethnical issues pertinent to the disease process. We're going to look at the impact of the disease process of the individual, how ARDS affects this individual, how it affects the family and possible society members. To sum this presentation up, we're also going to be looking at a list of problems that's related to ARDS and a plan of care for nurses relating to this disease process. So we're going to start off with the definition of ARDS. ARDS is also known as respiratory distress syndrome or wet lung. ARDS is a rapidly progressive disease which occurs in critically ill patients. It is a buildup of fluid in the tiny air sacs of the lung, also known as the alveoli. ARDS causes less oxygen to be able to get into the lungs, causing the patient to have shortness of breath. ARDS causes difficulty and the inability for one to breathe. This can cause a serious issue in this patient. ARDS is defined by three factors. The first one is timing. Whenever you look at ARDS, you see when is the onset of these respiratory symptoms. Normally in ARDS, this is going to be about a 1 week span of symptoms, so it's going to be pretty acute and sudden onset. You're also going to look at radiographic changes. You're going to be looking at chest x-rays. You're going to determine if there's any changes from their baseline status to their current chest x-ray. We're going to be looking for any condensation. We're going to be looking for effusions. And then you want to look at the origin of the edema. So when we're talking about the edema and the buildup of fluid in these patients, it's not going to be explained by their cardiac function, their heart failure, or fluid overload. A lot of this is going to fall back on to their respiratory symptoms. So the history of ARDS. ARDS is first come about, first really defined in World War I. It was recognized during this time period that there were patients with non-thoracic injuries with severe pancreatitis, massive transfusion, sepsis, and other conditions that cause these patients to develop this respiratory distress, these diffuse lung infiltrates, and respiratory failure. Sometimes these symptoms occurred within hours, sometimes days of these patients having these injuries. So a man by the name of Ashwell, and him and a few others had 12 patients with similar symptoms in 1967. These group of individuals started terming this respiratory distress in these critical ill patients as adult respiratory distress syndrome. The definition was further developed and revised in 1994 by the American European Consensus Conference. At this time, the term acute respiratory distress syndrome was used instead of adult respiratory distress syndrome. They found this to be in the fact to change the name that this respiratory distress did not only occur in adults but also in children and individuals of all ages. In 2011, the definition was further developed by a panel of experts using the Berlin definition. Some key facts about ARDS. ARDS occurs when there's trauma to the lungs. This could be directly or indirectly. This could be medical purposes, medical reasons, or traumatic events. Most developed ARDS when they're already in the hospital. Patients normally don't come into the hospital with a diagnosis of ARDS. They're going to be put into the hospital for other reasons, like possibly aspiration pneumonia. An individual comes in from outside with complaints of this. They'll be admitted into the hospital. Once they're admitted and placed in a med-surg or the ICU setting, these symptoms continually and rapidly occur until this patient then becomes diagnosed with ARDS. ARDS causes fluids leak into the lungs. This makes it difficult for oxygen to get into the blood. ARDS can also be associated with medical problems or procedures. This could be any surgical procedure that had complications as well. Incidence. We're going to look at the incidence of ARDS. Approximately 200,000 reported cases each year in the United States. Most ARDS, like I said previously, these individuals are already hospitalized and have a critical condition already whenever they are diagnosed with ARDS. Like I once previously said, this is also going to be because of any medical or trauma matters that this patient may be dealing with at the time.
I'm Tawanza McClendon, student at the MUW. Presentation on ARDS. I'll be discussing the risk factors. One of the risk factors is obesity, cigarette smoking, and a recent major trauma surgery. Alcohol abuse, low protein in the blood, and recent chemotherapy. The pathophysiology of ARDS includes fluids leaks into the lungs, making it very difficult to breathe. Leads to hypoxia. Fluid causes lungs to become firm and difficult to inflate. Increases the work it takes to breathe. This is known as fibrotic stage of ARDS when there's scarring of the lungs. This is just a picture of the difference between a normal lung alveoli and a ARDS alveoli. And as you can see, the scarring and the extra tissue that's making it insufficient for the lungs to actually inflate the way they need to inflate. This is just a diagram of how the inflammation of ARDS are in the alveoli. Causes of ARDS. The cause can be direct or indirect. Direct is like pneumonia, aspiration, near drowning, smoke inhalation. Indirect can be inflammation of the pancreas, sepsis where there's severe infection, blood transfusions, burns, or medication reactions. Causes of ARDS, the percentages, the most is a severe sepsis, which is 24%. No, the most cause of ARDS is pneumonia at 35%, and then next is severe sepsis at 26%. Common signs and symptoms of ARDS. You have cough and fever, tachycardia, tachypnea, chest pains, and cyanosis. This is another fun slide of ARDS. It shows you the signs and symptoms of ARDS. Diagnosis and prognosis. ARDS is a very serious disease process. Between 30 to 50% diagnosed with ARDS will die of it. Those surviving with often experience long hospital stays. Individuals may develop other complications along with this disease, such as pneumonia, collapsed lungs, kidney failure, and other infections. How is ARDS diagnosed? Is diagnosed by symptoms, vital signs, chest x-ray, rapid onset of symptoms such as shortness of breath and decreased oxygen saturation. Chest x-ray presents infiltrates, Fluid presents in both the lungs, and arterial blood gases, ABGs. This is a slide where it shows you the difference between a patient with ARDS and a patient without ARDS. This is a normal chest x-ray where these are opaque. You're supposed to be able to see through those. And over here you can see that you can't see pretty much anything through here. And those are how the ARDS patient, how you tell the difference between the ARDS and the normal. ARDS severity rate. The severity rate is based on the PaCO2, FiO2, 200 to 300. Moderate is 100 to 200, and severe is less than 100.
My name is Sherman Steverson, and I'm a student at MUW, and I will continue the presentation on ARDS, and I will just continue with treatments. And the treatments for ARDS will be the supportive care while the lung heals. Keep enough oxygen in the blood to prevent further damage. And also we have secondary goal prevention and to manage complication. We have the ventilator support, and we'll use a position as prone, and we'll also use kinetic therapy. And we'll also use sedation and preventative management and fluid management and extracapsular membrane oxygenation. Now there's ethical issues pertinent to the disease process. So if the patient with respiratory failure choose not to do the mechanical ventilation, then we should respectful and compassionate use the palliative measure to relieve the symptoms of respiratory failure. And withdrawal of patients from ventilators, special considerations relating to children, and withholding or withdrawing treatment. And we can see here with withholding the treatment, we never start a treatment, and withdrawal is stopping a treatment. Okay, and then we have the impact of the disease process on the individual, family, and the society. And some individuals prior to acute respiratory distress, they struggle with weakness, which causes them longer hospital stays, and then they have to seek more therapy. And with acute respiratory distress, many face anxiety, fear, depression, stress. So that means we may have to put them on some medication that will help them out with that, or either we'll just have to make sure we have those support groups to help those individuals out. And these individuals will need also neuromuscular, cognitive, and psychological symptoms. And survivors utilize increased health services post-discharge. So after they are released from the hospital, we use ways to help them maintain. And possible admission to a long-term ventilator or rehabilitation unit, because it's going to take a lot of therapy for these ones. Now we get to the problem list of acute respiratory distress syndrome and the nursing diagnosis as well. And the top 5 here would be the ineffective airway clearance, ineffective breathing patterns, impaired gas exchange, risk for infection, and risk for imbalanced nutrition less than the body requirements. And also the other diagnoses continue: the risk for a deficient fluid volume, activity intolerance, acute pain, deficient knowledge, and anxiety. And the plan of care for the top 5 that's prioritized, which is ineffective airway clearance, basically with the outcome, we want to show behaviors to achieve airway clearance and display airway with breath sounds, clearing the airway and the shortness of breath, and also prevent them from being cyanotic. And we have multiple interventions here for the patient with the airway clearance, and not just going to read through all of them, but we'll just see a couple of them, which is assess the rate and respiration of the chest movement, and also suction as needed, and make sure the airway is clean. There's no areas decreased or absent with airflow, and we also force fluids on the individual. All right, and then we have the one with ineffective breathing pattern, and the whole outcome of this, which should be free of cyanosis and establish normal breathing pattern. And basically interventions, some of the interventions is the same, which is you want to make sure they get enough fluid intake. You want to monitor vital signs and also suction is needed. And we also have impaired gas exchange. And the outcome of this is to make sure that the ventilation and oxygenation of the tissues by ABGs are within the patient acceptable range and absence of symptoms and respiratory distress. The interventions is going to be some of the same symptoms. You want to assess the respiratory rate, the depth and ease. Also, you want to observe the color of the skin, the mucous membrane, make sure it's moist, wet, pink. And also, you want to assess the mental status, make sure there's no change in that. And also, we want to monitor the ABGs and the pulse oximetry. And we also have risk for infection. And we want to do this, we want to identify and prevent and reduce the spread of infection or secondary infection. And goes back to the same thing, monitor vital signs. We want to change position of the patient. We want to monitor effectiveness of the antimicrobial therapy. And we want to investigate sudden changes in condition. Also, we have the risk for imbalanced nutrition, less than body requirements. And the outcome with that, we want to maintain and regain the desired body weight. So we want to make sure these ones are already decreasing oxygen and shortness of breath. So it's going to take a lot of energy for them to eat. So that's why we have to be concerned about maintaining the adequate nutrition. We want to elevate the patient head and neck to make sure their airway they're not blocked while they're trying to eat. And also we want to auscultate for bowel sounds and observe for abdominal distension. And that will be the end of the PowerPoint for acute respiratory distress syndrome. I hope you learned something today, and y'all have a nice day. Thanks.